And our topic is Aravind Pseudoexfoliation study, 10 years post-op results.
Good morning, thank you. So, the purpose of our study was to be a prospective comparative study of the late postoperative complication rates in eyes undergoing phacoemulsification, both with and without pseudoexfoliation. This was a prospective multicentric study done at the 4 hospitals at Aravind Eye Care System. The PEX group included patients who had pseudoexfoliation and visually significant cataract, and the control group had patients with cataract without pseudoexfoliation. Subjects were then further randomized to receive the various IOLs and capsule tension ring. The inclusion criteria was patients who had visually significant cataract with pseudoexfoliation, willing for phacoemulsification, an endothelial cell count of more than 1,500 cells. We did not include patients with phacodonosis or pupil size equal or less than 3 millimeters. Follow-up was done 1 day, 1 month, 3 months, 1 year, and yearly thereafter for 10 years prospectively. We did not do the 9th year follow-up because of the COVID pandemic. The pseudoexfoliation group included 970 eyes of 970 patients. Patients were randomized to receive either a single piece or a 3-piece acrylic IOL, and each of these groups were further randomized to receive a CTR or not. The control group included 476 eyes, and patients were again randomized to receive a single or 3-piece acrylic IOL. None of these patients received a CTR. The primary outcome variables were IOL decentration and ND-YAG capsulotomy rates, and secondary outcome was the visual outcome. The first year postoperative results, the surgical and first year postoperative results, the analysis showed that pseudoexfoliation eyes without clinically apparent preoperative zonulopathy were not at a higher risk of intraoperative or postoperative complications or worse visual acuity after cataract surgery. Again, at the 5th year follow-up paper, our conclusion was that the risk of IOL decentration and PCO were low in pseudoexfoliation eyes and comparable to those in control subjects. And also with uncomplicated pseudoexfoliation, neither the IOL choice nor the presence or absence of a CTR affected the outcome at 5 years. This slide shows the follow-up at each year. At the 10th year follow-up, about 21.6% of the patients had died, 65.5% followed up, and 13% were lost to follow-up. So excluding those patients who were died, about 83.2% of the patients completed their follow-up at the 10th year. The IOL decentration rates were 2.27% in the pseudoexfoliation group and 1.68% in the control group, and this difference was not statistically significant. Most of these decentrations were mild, except for one patient who required IOL repositioning and iris fixation. YAG capsulotomy rates were also similar at 5.5% and 5.67%. Looking at the risk factors for IOL decentration using the Cox proportional hazard model, the 2 risk factors we identified were capsular phimosis. The patients had a higher risk of decentration, and if the rexus did not overlap the optic edge during surgery, this was also a risk factor for IOL decentration. And risk factors for ND-YAG laser for PCO, single-piece IOLs had a higher risk of PCO compared to the 3-piece IOLs. Younger patients less than 60 years with probably more viable lens epithelial cells had higher risk for PCO. And again, if the rexus did not overlap the optic, these patients also had a higher risk for PCO. Looking at the logMAR visual acuity at the different follow-up visits, the pseudoexfoliation group had lesser vision than the control group at year 2, year 3, year 6, year 8, and year 10. Now, however, since this difference was statistically significant, but clinically this was not very significant. If you look at 0.12 versus 0.08 at the last 10th year follow-up, this both comes to about 6 by 7.5 visual acuity, so it is not a very different outcome in terms of the visual acuity. Comparing another study which looked at 10-year follow-up retrospective data, they had 0.22 in the non-PEX and 0.27. In our study, we had 0.08 and 0.12 as the final outcome. In conclusion, this is the first large-scale prospective comparative study with a long-term follow-up evaluating pseudoexfoliation eyes undergoing phacoemulsification. And in those eyes without phacodonosis and without small pupils, pseudoexfoliation did not confer a higher risk for decentration or PCO. Thereby, CTR is not required prophylactically in these eyes who do not have phacodonosis. And in these eyes, the choice of IOL did not matter, and the visual acuity was also comparable in both the groups. Thank you.
Very nice study, ma'am, and with a great sample size.
Hello, ma'am. I just want to ask a few questions. So, was IOP not considered in this?
Yes, we did.
Or the
That is a different
glaucoma
paper.
did-
So we did have, when we started off, the pseudoexfoliation group's IOP was 14.3 and the control group was 14. Again, this was significant statistically, even to begin with, because the number was large, but again, not a big difference. So we also at each follow-up did, but this study we looked at only
Okay.
decentration.
In this paper, was phacodonosis and I mean, in
excluded.
they
So
were
we
excluded.
did not include patients who had it either pre-op or during surgery. If we found any phacodonosis also or zonulopathy, we did not include those eyes.
Was the grade of that pseudoexfoliation noted?
So there was no actual grading. So we developed our own in-house way of saying, what is the grading. So there is no published literature which says this is how we can grade.
Any dislocation of IOLs?
Only
you
one
noticed in this?
patient had a significant decentration but required iris fixation. All the rest
No
are still doing.
dislocation as such in
No
the 10 years
dislocation.
of
No.
follow-up.
This one patient had pseudoexfoliation, so just the rate was extremely low. Just one patient over these 10 years follow-up had needed a refixation.
So have you put toric IOLs in pseudoexfoliation?
No, these were all straightforward monofocal. This group was all monofocal, but we do use toric IOLs in pseudoexfoliation if they've had no preoperative zonulopathy.
Okay. So are you doing any study on toric IOL pseudoexfoliation?
We are not doing any study on that.
Madam, what I feel that at the end of the day, let's after 6 years or 5 years or 10 years, a long-term basis, there is some amount of phimosis, and these phimosis will little decenter your IOLs, and if you're doing torical, it will give you a bad effect and.
Yeah. So I think phimosis, I think most of it in pseudoexfoliation especially comes earlier on. So after the first few months, it may not come, but those eyes are definitely at a higher risk for further zonular loss and decentration. And the phimosis itself, as we know, toric IOLs, what is important is critical for the lens to stay in place is the first day, and the phimosis probably happens within the first month or two. So I think within this time, if it stays, you will not see a rotation of the lens per se, but we may see a decentration of the whole capsular bag complex, which I'm not here to say for sure because we don't know that data. We didn't do
we
that
have
study.
a study. We have a long-term study on the follow-up on such cases, and we found out that in uncomplicated in a long term, you get phimosis. Whether it's what grade, probably it has to be done. A little bit of phimosis or more phimosis to the extent of the even the decentration and subluxation.
True.
So the decentration which you got, was it in the earlier phase, like less
No,
than?
it lasts the 10th year follow-up.
10th year follow-up.
Yeah, we just had one patient. Thank you.
You have already published this study.
Not yet. No, we have only published the
5
first
years.
year and 5th year. This 10th year data is new, so we're just analyzing this. This is, the 5th year